Alright, so this is a follow-up to the last video with some updates on the Parkinson's neurology fiasco that I'm dealing with right now. My hope is, I hesitate to say this because I have this PTSD response of if I say that it's not going to happen, it's going to happen. So I have this anxiety of saying, like, I will be told that I don't have this in a short period of time. I'll jinx it and I'll end up having it. But based off of everything I said in that last video, I'm of the opinion that the doctor who saw me has some gaps in his awareness and understanding of what he's looking at with me, and I therefore cannot rely solely on his input. And my hope is that I get this dopamine scan in at the end of July, and the dopamine scan tells me that this is not a concern for this condition, or, at the very least indicates that I don't have anything worse. There are a couple of conditions that are actually worse. But at the outset, my hope is that we get to the point where part of these videos that I update and upload subsequent to this one will be more discussion of how a diagnosis is not necessarily flawless. Because that's one of the things I've talked about with the autism spectrum stuff is everybody treats it like being diagnosed as, the Midas touch. You've triggered and found out what the actuality of your condition is. And that's not how that works. Specifically, in the case of this Parkinson's fiasco, is their current modality of diagnosing this stuff is off the opinion of a guy whose personal biases can be a problem for the diagnosis process. And the same holds true for autism. There's no brain scan you can do to determine whether or not somebody has autism. It's completely based off of, well, this seems like an autistic person to me. And you would hope that the person making that statement was somebody who had an objective and skilled understanding of the signs and symptoms of the conditions so that there isn't wiggle room for interpretive process in the diagnosis. But there is. And there are a lot of people out there who are diagnosing people as not autistic because they believe fully that you have to be a male. Some of them believe that you have to be learning disabled. So, like, you have to be nonverbal or hit yourself when you're stressed. You have to look like Rain Man. That's not how that goes. And these are professionals. These are professional psychologists and psychiatrists, MDs and doctors, PhDs. And their methodologies of diagnosing these things is so demonstrative of exactly what bothers us autistics about stuff like this. Like, I know I can look at a clock and tell you this hand is here, this hand is there, therefore it's this time. I struggled a little bit when I was younger with analog clocks that didn't have a click to the next spot, in part because the hour hand will be between 4 and 5. So it's not telling me it's 4 o'clock when it's 4:15. It's telling me it's 4 and something Just the hour hand alone tells me it's four hours and something minutes. But my brain just looks at that and goes like, well, it's not on a 4 or a 5, so it's not 4 and it's not 5. I struggled with the analog clocks for that reason when I was younger. So this idea of a diagnostic process that doesn't have a yes it's this or yes it's this, it's just kind of like maybe. That doesn't sit with us well, or doesn't sit with me well. I can't speak for other autistics. Some people probably had no problem with that stuff, but typically speaking, an autistic person is more prone to being disconcerted by uncertainty. So if you're looking at some kind of diagnostic of what are your conditions, what are your problems, we want the ability to look at a thing and go like, no, this is this, that is that. You don't get that with a lot of this kind of stuff. Specifically when it's clinically diagnosing things like Parkinson's or autism or ADHD. Like there's no test you can run to confirm those diagnoses. Now we're getting to the point where we're understanding things like Parkinson's better. So one of the things we're supposed to be doing in the next 2 or 3 weeks is doing what's called a DAT scan, a dopamine something scan. It's testing there's a certain region of your brain that produces and absorbs the most quantity of dopamine. And it's the part of the brain that gets progressively more damaged in Parkinson's disease. So the scan takes a look at the dopamine uptake in that region of the brain to see whether or not that uptake is happening at a rate that suggests damage or diminishment of that region of the brain. Well, my asking them whether or not they're false positives got a hasty 0 false positives. That's never the case. If you were to show me the scan of any 2 people having a DAT scan, any 2 neurotypical people having a DAT scan, your DAT scan's going to look different even if you do one person. So you take somebody at the age of 20 and you give them a DAT scan, and you gave that same person a DAT scan at the age of 47, like I am, then that DAT scan will show a diminishment or weakening or thinning of that region of the brain. Now you take any 2 people and you'll have different rates of diminishment of that region of the brain. In otherwise healthy individuals, the appearance will be different for each of them. Now throw on top of that the fact that post-traumatic stress disorder, ADHD, autism, anxiety, depression, they all affect the dopamine centers of the brain to some degree. That's at least one of the working theories about some of these conditions, is they're changed by differences in dopamine levels. So my question still remains a legitimate one that has not been answered. What does those differences look like when put into the field of trying to determine Parkinson's? So what's the odds that somebody with post-traumatic stress disorder and autism spectrum disorder, both potentially having mechanisms of affecting the uptake and production of dopamine in regions of the brain, what are the odds that their presentation as seen by a DAT scan could send signals to somebody looking at it as being deficient or damaged in those regions, when in fact this is exactly how they're supposed to be functioning for what their conditions are, and is not indicative of a Parkinson's progressive neurological degeneration situation. They dismissed it and say there's 0 false positives. Like, that's, first of all, if you have any test that requires that you can put the test results up on the screen and I can't look at them and go like, oh, that clearly is worse than that one, it means you need somebody with expertise and understanding of the nuances of those scans to be able to interpret them. And anybody who's ever interpreted complex data knows that anything that's that close to each other that you need an expert analysis to be able to understand isn't something that you can claim a false positive ratio of 0. That's not how that works. So I'm a little skeptical of this test. Honestly, if you were to ask me what I thought would be a better approach for doing these kind of diagnostic tests, I do think there's a spinal tap test you can do for testing proteins in the spinal fluid. Not interested in that right now, but ideally what you would do is do a DAT scan 3 years apart. So if it's a progressive neurological disorder, you will see the progress of the disorder over time. That'll tell you more. You take an example of a person at different points along a timeline. You're seeing the progression of a progressive disorder. Otherwise, I feel like it's a little bit hazardous to just put all the weight on somebody's opinion of how you touched your nose with your eyes closed or whatever. That's just unacceptable as a diagnostic criteria as far as I'm concerned. But even if you put aside that concern and move into the idea of using a scan test like a DAT scan, there's a part of my mind that says, like, unless you have a good example of every different neurotype as it goes through this process, how can I trust anything that comes out of this test? And so, yes, it's possible that a part of me is just being resistant and in denial about this potential diagnosis. That's a possibility. I don't know that that's what I'm doing, because I feel like the procedure that I went through for clinical diagnosis was not up to snuff, and his notes afterwards were incorrectly summarizing things that weren't happening that way, and it was a mess. Add to that the fact that I saw for a year and a half before I saw this guy, I saw a different neurologist who found no problems that he could find. He found no explanation for why I have the little shaking on my pinky and ring finger, but he found no problems that he could diagnose a health problem with. So, I mean, like, it all sums up to me that, like, this is a terrible way to treat somebody who's coming to you asking for help and diagnosis, or coming just asking for help, understanding and reassurance about something that's weird with his body. And the end result is you've now given me a diagnosis without really understanding the evidence and the symptoms going on. And it just feels like it doesn't feel good to be left to fend for, like, the whole thing at the end with the, if you have any questions, look it up on Dr. Google. No, that is not how we do neurology. It is definitely not how we treat people who have potentially just been diagnosed with a neurodegenerative disorder with a lifespan of about 10 to 15 years afterwards, average. That's a terrible way to do anything. So, yeah, no, I have my qualms about taking any of this to heart too much right now. We're running up on 15 minutes again. I will cut it here, and I will potentially talk about something a little bit different next time.